Thank you. Now I'm going to change the topic a little bit to the treatment of obesity. Those are my disclosures. The big change came about really in the trials of the new drugs for type 2 diabetes, the GLP-1 receptor agonists. And it was shown that with liraglutide there were benefits in terms of cardiovascular events and cardiovascular deaths, and then again with semaglutide, dulaglutide, and oral semaglutide. But really the big change came around with the LEADER study, and it showed a significant benefit in terms of the major adverse cardiovascular events and death from cardiovascular causes. And I guess in a way it was a bit of a surprise. You know, these studies were going on to show that these treatments for diabetes were safe, that they didn't increase cardiovascular risk, which had been seen with rosiglitazone. And then it was perhaps something of a surprise to see this benefit. And when you look at all the outcomes with the LEADER trial, overall death was reduced. So it was really a major breakthrough to see this benefit. Now, a few years ago, we compared the GLP-1 receptor agonists and SGLT2 inhibitors. And of course, they both have advantages in cardiovascular risk factors, but they're slightly different. Probably the GLP-1 receptor agonists are more effective in reducing HbA1c. They're certainly more effective in reducing body weight. You know, SGLT2 inhibitors do reduce body weight, but maybe only 2 or 3 kilograms. They're not really a treatment for obesity. They are a very well-established treatment now for heart failure, throughout the whole spectrum of heart failure, but not for obesity. And one peculiar thing about the SGLT2 inhibitors, they don't reduce LDL cholesterol. They maybe reduce triglycerides a little bit, but they don't reduce LDL. On the other hand, GLP-1 receptor agonists seem to have benefits right across the cardiovascular continuum, except they increase heart rate a little bit. And that is a well-established effect of most of the GLP-1 receptor agonists. So GLP-1 receptor agonists have an anti-atherosclerotic effect. And of course, liraglutide has been approved now since 2014 for weight management in adults, and more recently it was approved for weight management in children down to the age of 12. And in fact, more recently, even this year, there's been a study down to age 6, but it hasn't got that approval yet. So the high-dose liraglutide is approved from age 12 upwards. And it's very worrying, really, that we see children of age 12 needing this sort of treatment. You know, and this is really a lifestyle problem in most of them. Now, we reviewed the anti-obesity drugs again about 5 years ago. And at that point in time, liraglutide had been approved for a treatment for obesity. But if you go back before liraglutide, the other treatments actually were harmful. Sibutramine increased cardiovascular events. It had a sort of symptomimetic activity. Rimonabant looked very promising, but then it had some psychiatric type effects, and it was withdrawn from development. So liraglutide was looking very good, and at that point in time, we also felt semaglutide is going to be a game changer, which it is. So the trials with semaglutide, like Pioneer 6 with oral semaglutide, showed benefits in terms of major cardiovascular events. It reduces HbA1c very well. It reduces body weight, but only modestly. The body weight reduction with oral semaglutide is only about 3 to 4 kilograms, not so much. But it did reduce all-cause mortality. Now, of course, going on and going into the last couple of years, there are new studies coming along. More studies with semaglutide, and then we have tirzepatide. So this was the study with oral semaglutide, the sole study in high-risk patients with type 2 diabetes. Again, we can see a significant benefit. It reduces cardiovascular events, it reduces A1C, it reduces body weight. And then we go on to look at patients with obesity who don't have diabetes. So here we have the SELECT trial with semaglutide. This is given subcutaneously once a week, and the primary cardiovascular endpoint is significant. So again, whether the patient has diabetes or not, if they have obesity, semaglutide can reduce cardiovascular events. And it reduces pretty well all of the cardiovascular risk factors. You can see in this table maybe it's reducing blood pressure, it's reducing lipids, and it also reduces inflammatory markers. It reduces CRP. And then there are some studies with semaglutide in heart failure, in HFpEF, heart failure with preserved ejection fraction. So this was the one in patients without diabetes, the STEP HFpEF trial. This is not an outcome trial. This is just a trial to look at the effect on body weight and on symptoms related to heart failure. And it shows a positive benefit. It improves these two measures of outcome, not cardiovascular events, not mortality, but short-term benefits. And the same was true in the STEP diabetes study. So again, patients with HFpEF, heart failure with preserved ejection fraction, and diabetes, a common combination. Again, semaglutide improves these symptoms and, of course, reduces body weight. And semaglutide, remarkably, only last week got the approval from the FDA for metabolic dysfunction-associated steatohepatitis, MASH. So semaglutide now in the United States is approved for MASH. I think that's a big step forward. It's not the only drug of this group that reduces MASH, but it's the only one that's got the approval, I think, at this stage. And this was based on the ESSENCE trial, which was published quite recently. So I think that's a big step forward, and that's something that you could consider because this is such a common problem nowadays. And again, semaglutide in the high dose formulation, the Wegovy, has been approved for adults and children aged 12 and older for quite some time for weight reduction. Now moving on to tirzepatide. So tirzepatide is a special molecule in a way. It combines the effects on GLP-1 and GIP. The molecule is a bit more like the exendin molecule than native GLP-1. And these molecules, these peptides, all have a fatty acid chain attached to them to prolong their activity. So this slide has a lot of text on which you can't read, but it just shows the main actions of GLP-1 and GIP, and if you just look at the top box there, GIP is thought in a way to reduce nausea. So you might expect that tirzepatide would have less nausea than pure GLP-1 receptor agonists. And I'll come back to that. So tirzepatide is very effective in reducing body weight. In obesity, in the SURMOUNT-1 trial, it reduces body weight in a dose-dependent way. You can get reductions of over 20% in body weight with the higher doses of tirzepatide. And again, all the cardiovascular risk factors are reduced. Triglycerides reduced 16%. Here's a list of all the things that are improving with tirzepatide. So it's a very effective treatment. In the SURMOUNT-4 trial, again, tirzepatide was used, and then after the first period, the patients are randomized either to placebo or to continue tirzepatide. Now it shows that when you stop tirzepatide, things go back to baseline. Slowly enough, but eventually, probably, the patient will go back to the original weight. So it just goes to show that you probably need to carry on with these treatments indefinitely. So summarizing the treatments with tirzepatide, SURMOUNT-1 to 4, you can see that there are these major reductions in body weight, the main bars going down, and these to some extent are dose dependent, so one tries to get up to the maximum dose of 15 milligrams. And again, it's sort of what you might expect. The greater the weight loss with tirzepatide, the greater the reductions in cardiovascular risk factors, systolic blood pressure and triglycerides. So the more weight goes down, the more everything improves. And there is the comparison here, the SURMOUNT-5 trial, comparison with semaglutide, tirzepatide and semaglutide. And you can see that tirzepatide was more effective here, reducing the body weight by 21% compared to 15% with semaglutide. And again, change in waist circumference followed that pattern. Now, if we look at the SURMOUNT-5 trial, you can see I mentioned that nausea may be less with tirzepatide than with the pure GLP. Now, in this study, actually, it's the same, but of course, tirzepatide had a greater effect on body weight. So although it has a greater effect, it didn't cause more nausea. There are a couple of other things that one sees on this, which perhaps not expected. Alopecia is quite a common adverse effect with both of these drugs. And one thing to think about, you know, we know that gastroesophageal reflux is a problem of obesity. So you might think if you reduce obesity, it will get better. But in fact, with these drugs, it doesn't get better, it gets worse, you know, because they reduce gastric emptying. So don't expect your patient's gastroesophageal reflux to improve with SGLT2 inhibitors or tirzepatide. Now, we tend to think of the SGLT2 inhibitors as being useful for the kidneys, but in fact, also the GLP-1 and the GIP combination are beneficial in terms of renal function. And that's been shown whether you measure the GFR with creatinine or cystatin. And indeed, there's a study with semaglutide, the FLOW trial, showing that semaglutide improves the kidney disease progression. So we do have evidence that the SGLT2 inhibitors are also useful in kidney disease. It's not SGLT2, GLP-1. So is there any downside to using the GLP-1 receptor agonist? Well, of course, there are. There are some adverse effects in different organs. And of course, gastrointestinal disorders are very common. Nausea, vomiting, diarrhea, or constipation. Some people get one, some people get the other. There's a worry that maybe there's a reduction in lean body mass, in muscle mass and bone loss. A concern about pancreatitis, which has really not been established. Biliary disease, there is an increased risk of gallstones in some studies. Maybe suicidal ideation, not proven, I think. Now, of course, there are these things which are reported. Maybe people start to look miserable after they've lost all this weight. They should be looking happy here, but the so-called Ozempic face, and there may be a problem with periodontitis because of dryness of the mouth, so-called Ozempic mouth. Now, and again, very recently, the FDA have put a warning about risk of serious kidney injury with GLP-1 receptor agonists, largely because of dehydration. I think it's very unusual, but this warning has been added now to some of these drugs. And in fact, if you look at the prescribing information with the more common GLP-1 receptor agonists, there are a whole list of things: pancreatitis, gallbladder disease, and so on. And at the bottom, thyroid seed cell tumors, which comes from animal work, which has not really been substantiated in humans. Now, there are new things coming up, and there's one drug which is a non-peptide small molecule. This one, autoglipron, relatively small molecule, taken orally. You may be aware that semaglutide has a very low oral bioavailability, maybe only 1%, but this is well absorbed and it's very effective. It still has the same sort of adverse effects in terms of nausea, vomiting, and diarrhea, but it's more effective here than dulaglutide. So this oral drug may turn out to be another great benefit. And there are other combinations. There are a combination of three different receptor agonists, not only GLP-1, GIP, but also glucagon. So there are all sorts of different combinations in development. This is just one of them, retatrutide. It's the triple hormone receptor agonist, very effective in reducing body weight, up to 25%. We're getting to the level that you can achieve with bariatric surgery now. So these drugs can reduce all of the cardiovascular risk factors very effectively. And there's a combination of semaglutide and cagrilintide, which is an amylin agonist. And again, this produces greater effect than either drug by itself. So a number of combinations in development. This is the redefined 2 with that combination. In patients with overweight or obesity and type 2 diabetes. So in conclusion, we've seen that some, not all, of the GLP-1 receptor agonists, particularly semaglutide and the combination with GIP, tirzepatide, very effective in reducing body weight and reduce all the multiple cardiovascular risk factors: blood pressure, lipids, hsCRP. And the greater reduction in body weight, the greater the reduction in these risk factors. So they can improve symptoms and outcomes in HFpEF and kidney outcomes, and some have shown improved cardiovascular outcomes. We don't have the study with tirzepatide yet, but that will be coming along soon. So I think this offers a new opportunity for patients with obesity. We can now give treatments which have benefits really right across all the risk factors, and I think these drugs are going to make a big change in patients with diabetes and without diabetes. So thank you very much for your attention.